panel's title is Community Engagement, How Healthcare Reform is Refocusing Attention on Communities as Partners in Education and Care Delivery. I'm going to moderate the panel. My name is Marian Grant. I am the Director for Policy and Professional Engagement at CTAC. I am also a practicing palliative care nurse practitioner. I see patients a few times a month in one of the large medical centers in downtown Baltimore. And I guess I should say that, like Bill Novelli, my previous first career was in brand management, where I worked on the Vidal Sassoon and CoverGirl business, and then left, like so many, to go into nursing and palliative care. Joining me on the panel today, wonderful participants, we have Harriet Warshaw. She is the Executive Director of the Conversation Project. Now, we have referred to this a number of times, and I think that's a bit of a teaser because Harriet is going to tell you much more about her organization and the important work that they're doing, especially here in the Massachusetts and Boston area. And then also joining me is the Reverend Tyrone Pitts. He is the General Secretary Emeritus of the Progressive National Baptist Convention, which he tells me is the denominational home. It was the denominational home of Reverend Martin Luther King Jr. Reverend Pitts is also a senior advisor at CTAC, and he is the chairman of the board of the Morehouse School of Religion. I'm always a little nervous to be on the podium with a Baptist preacher. He's quite inspiring, and we will all be inspired by what he has to say. The objectives we have for the panel are to discuss a little bit the link between healthcare reform and community efforts. To discuss a little bit, we're going to have Tyrone speak next about CTAC's community engagement efforts, and then Harriet will speak about the Conversation Project. We'll allow enough time for questions. So hopefully you can be thinking of that as we go along. As I thought about this panel, and what was the link between healthcare reform and the refocus on community, it seemed to me that there are probably a number of factors, but two came particularly to mind. And the first one is that phrase we love to hear and to use, which is patient-centered care, or person-centered care if you're particularly progressive. I don't know about here in Boston or here in Cambridge, but back in Washington, this is a big buzzword, right? Everybody talks about it. But I have to tell you, and I think Amy already paved the way on this, from the clinical practice world that I live in right now, I'm not seeing this so much. When I think of what patient-centered care is, I think it means a fully informed and appropriately informed patient who is actively and engaged in their care as a partner with their medical team or their healthcare team, and whose values and goals are driving their medical care. And yet, what we see is that that is often not the case. That process is dependent on having trusted relationships. And that is also something that we don't see. Obviously, there are some patients who have wonderful relationships with their providers or the medical team. But I have to say, in the hospital, as I look around, I don't always see that. But patients do have trusted relationships outside of the healthcare system, certainly with their families, but particularly with their communities. And I think that this is a place where we can look for help with really delivering patient-centered care. Somebody asked a question right now about pain and spiritual distress. And when I think about advanced illness, which I think about a lot in my line of work, I think that a lot of the questions that it raises go way beyond medical and physical questions, right? I mean, if you have an advanced illness, you're asking, why did this happen to me? What is going to happen? Why am I suffering? Is there a meaning in my pain and in my discomfort? And I think that those are questions that are much more appropriately answered for instance, by a spiritual advisor than they are necessarily by a medical one. So I think that thinking about the community in those terms can be providing very helpful resources. Now, many healthcare systems have kind of figured this out, but they tend to approach the community in a top-down fashion. I think somebody else said that this morning. You know, they go in with their agenda, and that is really not the way to engage the community, because actually the community knows what their agenda is. They know what their issues are, and it needs to be much more of a partnership. Now, the second factor that comes to mind about why why we're rediscovering the community has to do with the fact that we realize a lot of medical issues are actually not so much medical issues as they are social issues, right? I was at a presentation in Washington last week where a wonderful primary care physician told a story. She had a patient who had diabetes. They had a wonderful, trusted relationship. They worked very closely together, and yet this patient, every month, but at the end of the month, had problems with her blood sugar. They got totally out of whack. And several times she actually had to be hospitalized over that. And it was finally the medical tech in the primary care clinic who said, you know what? I think she's on food stamps, and I think she runs out of food by the end of the month. And it turned out that indeed that was the issue. But because she was such a good patient, she continued to take her diabetes medication, even though she wasn't eating. So that's an example of somebody who has a medical issue, yes, but it's exacerbated by social issues. And I have to say, as both a policy person and a clinician, for my money, one of the best things Medicare has done in a long time is the 30-day readmission penalty, the rehospitalization penalty. Now, you can debate whether it's appropriately administered or not, but before that, the only people who knew that the patient was likely not to make it to their follow-up appointment because they didn't have transportation, or who couldn't get to their pharmacy because it was in a dangerous part of town and they didn't drive at night or they didn't have the money, was the discharging nurse, or maybe the social worker or the case manager. And it is a lovely thing now to be in the hospital and have young residents come up to me and say, Marion, they don't have transportation. And I'm like, no, really? So it's opened everyone's eyes to the fact that there are many needs for increased social infrastructure beyond what the health system offers. But again, there's a community out there that needs to be engaged in that process. So I'm looking forward to our conversation about the link between healthcare reform and the community, and I think we'll start with Reverend Pitts.
Thank you very much, Marion. I am delighted, first of all, to be here. This is a very exciting conference that is open to possibilities to really deal with issues of advanced care. I also want to thank the organizers of this conference because you are taking a leap of faith. First of all, having me up here, and secondly, opening yourselves up to some possibilities that are beyond belief. Let me first of all start my presentation focusing on this issue of advanced care by saying two things. On March 25th, 1966, Dr. Martin Luther King, Jr., speaking before the Medical Committee for Human Rights in Chicago, Illinois, stated that of all of the forms of inequality and injustice, health care is the most shocking and inhumane. Since 1966, 51 years later, that statement would hold true today. And as we began to talk about the issue of advanced care and how we organize in our various communities to deal with this issue, I want us to focus on this effort from the American African community. Because I think for us within the church community and the interfaith community, it is critical that we deal with some of the issues that we need to lift up. Racial disparities in healthcare are so salient that to develop a model of advanced care without reference to systemic racism in urban and poor American African communities today is difficult to imagine. Racializing justice in health, care, or the process of racialization, or becoming conscious of the centrality of racism in the American historical experience must be addressed, as one of a major law professor, Kimberly Crenshaw, calls the intersectionality of race, class, and gender. Poor American Africans and racial ethnic people continue to struggle with advanced illness, and often they are the sickest and the most vulnerable. Although the shining light that has emerged over the past several years has been the Affordable Care Act, even with its limitations and challenges, it is a step forward. It is neither comprehensive nor effective enough to change public policy. And one of the interesting things about the Affordable Care Act is that those who struggled for this particular policy early were the very ones who have condemned it presently. It is a broken system, and we who are part of the political efforts to change policy must begin to think through how we relate to our communities in ways that have authorized people to become a part of this process. For many in the interfaith community, the most impressive effort that has been initiated over the past few years is that effort to transform advanced care. One of the issues that we have been dealing with historically is how do you deal with trust within various communities? And what we have been doing is we have been looking at several possibilities of developing trust, which has been one of the major problems in our communities due to experimentation, due to issues of non-reconciliatory processes, and due to issues where experimentation and evaluations are done without people's permission. And so what we're trying to do within the CTAC Coalition to Transform Advanced Care is to, one, connect the dots, and two, to build bridges among those who have historically been left out of the process of dealing with advanced care. We understand that there are power centers that must be bridged in order to become more engaged. We have been a part of conversations throughout the country where individuals have said to us from the clergy and from also other interfaith groups that we have been invited to the table, we sit at the table, but when we sit at the table, we are not able to really participate in decision-making that is critical to our life and witness with the health community. One of the important processes that we are engaged in also is to bring together health professionals, clinicians, individuals who have advanced illness, and try to find support systems for them. In a real sense, with all of the challenges and conflicts and the racial divide in our nation, we as the Interfaith and Diversity Working Group view this moment as a Kairos moment. And we clearly lift that up as part of who we are. Dr. Lily Brown Douglas, a prominent theologian in Baltimore, described this moment best when she states, "It is through chaos and crisis that God is fully present, disrupting things as they are providing an opportunity to a new future, to God's future. Kairos time is therefore God's time. It is a time bursting forth with God's call to a new way of living in the world. It is God's calling us to a new relationship with our very history and sense of self, thus the new relationship with one another and even with God." And we also say that this is a spiritual moment. It is a moment when not only does God within God's own self pull us together, but it's a moment when those who are not faith-based individuals find some sense of their own humanity in this whole process. Critical to this movement is CTAC dealing with issues that has historically created the schism in healthcare, and in creating a new paradigm to deal with issues that affect each and every community. There are several scenarios that I would like to lift up here. Number one, as we have gone through the process, we have found pastors and lay people who cannot really discuss the issue of death and dying. One of my very close friends, when he and I talk on a regular basis, I'll say, "How are you doing?" And he'll say, "I'm dying." And I'll say, "Are you dying now?" And he'll say, "No, I'm not, but I'm still dying." And then he'll say, "Are you dying?" And I say, "No, I'm not dying." So we get into this whole scenario of who is dying. The reality is that death is inevitable. And what we are doing, all we are doing is dying. So one of the things that we are trying to do in CTAC is to take a very critical look at death and dying, but also to reconfigure language. We do not use the word patient. We use the word people. We do not deal with the issue of curing. We deal with the issue of healing. We are trying to really pull the community together to redefine the community needs and to deal with the community in ways that the community wants to be dealt with. We have also been clear that we do not parachute in a community, but what we do is we work collectively with members of the community to begin to develop relationships and trust. Our major foci in this whole process is dealing with the issue of Ubuntu, which is the South African word which means I am because we are, and we are because I am. It is a word which redefines community as being co-workers and co-sharers in a process where whatever affects one individually affects us all collectively. It is a word that pulls together doctors and nurses and clinicians and healthcare professionals and community organizers and faith-based people to begin to have serious dialogue on a level playing field. It is a word that creates tension, but also creates possibilities for solutions that are important for us as we deal with the issues that face us in each day. And finally, I want to just lift up two scenarios that have happened recently in our lives as CTAC. One of the members of CTAC contracted hepatitis C, and she had hepatitis C for 20 years. She's 77 years old, and she finally went to her doctor and realized that there was a cure for hepatitis C. And she tried to get the drug, but could not get the drug, as many of you know, because it was, one pill was $1,000 per pill, and she had to take it for 30 days. That was $30,000 plus that she would have to generate from her own bank account, but she had no money to do that. Finally, some of the doctors and hospitals and physicians got together, and they decided to purchase the pills for her. They purchased the pills for her. She no longer has hepatitis C. She's living a very healthy and fruitful life, and she is a part of a CTAC team that is forcing us to deal with the issue of how prescription drugs become so burdensome that people cannot afford them. The other scenario I wanted to mention is the one of my brother-in-law who died 4 months ago. He was a musician. He had problems with his health plan. He got off the health plan and found out that he had esophageal cancer. He then decided that he needed to get back on the health plan, could not, but he got on one through the Affordable Care Act. He could not get his cancer, quote unquote, cured. But what happened was his wife decided that it was better to take his pain medication from him because she thought he would live longer. And so he died a horrible death in pain because of the relationship that she and he had. And there was no support system other than the family to really try to go through this process. Again, an Asian person who was dealing with the issue of advanced illness, who could not really come to grips, whose family could not come to grips with that reality. What we are trying to do is to pull people together to change the reality. but we're also pulling people together to create a new paradigm and to force the issue of struggling with policies and programs that do not affect and support the American African community or interfaith communities throughout this nation.
Thank you. Thank you. Again, thank you for inviting the Conversation Project to be part of this very important day. Thank you to Bill and to Andrew for setting up the Conversation Project, and to Amy, all wonderful partners in the work that we've been doing. I thought I would take a step back, since you've heard the term now several times, and tell you a little bit about the Conversation Project and how we are working collaboratively within community settings and within healthcare systems. So the Conversation Project is the ultimate in people-centered care, because it was started by a genuine person, Ellen Goodman. And I don't know if that name resonates with people in the audience, but Ellen, as you might know, a Pulitzer Prize-winning author and columnist for the Boston Globe for many years. But Ellen also was a daughter and a caregiver, like many of us in the room today. And when her mother became ill and had dementia, the problem was that the one conversation that they never had was how Ellen's mom wanted to live at the end of her life. And so Ellen was placed in that challenging position that all caregivers are placed in, having to make decisions on behalf of her mom without really knowing what was important to her. And if Ellen was here today, she would say to you she really wished that she had her mom's voice in her ear, because she felt blindsided by the different decisions she'd have to make. After her mother passed away here in Boston at Hebrew Senior Life, Ellen went to Len Fishman, who was the executive director of Hebrew Senior Life. And to Len's credit, instead of getting defensive, as many administrators do, and I was an administrator for 35 years, so I know all those, when family members march into your office and complain about something, it's very easy to recoil. But to his credit, he said, you know, Ellen, it's not just a problem for the patient or for the family member. It's a problem for the whole healthcare system. It's a problem for the whole country. And together, they went to IHI, the Institute for Healthcare Improvement, and shared this idea and concept with Don Berwick. When it resonated with Don, and he said, let's bring together an expert panel of people in palliative care from all over the country and see how we can help move the needle forward, see what they have to say, since they've been toiling in this field for so many years now. And this happened about 5.5 years ago. And to his credit, they spent a day together talking about how to move palliative care together. And it was the clinicians who said, what we need is a two-prong approach. We will continue to working on the inside for education and systems change, but we need to have an activated public. We need to push from the outside in as well as the inside out to change. And for those of you who might have had children in the 70s, you might know that, and I worked at the Boston Hospital for Women, so I was there. In the mid-70s, there were no husbands in the delivery room. The only men in the delivery room were the obstetricians, because there were still no female OBs. And yet, when women said they weren't going to deliver in our hospital, I can tell you in a nanosecond, those policies change. And that's what we'd like to see happen, that we have an activated public and they push policymakers, healthcare providers, they work collaboratively to change the way we live at the end of our lives. So how do you take a concept and create an organization and make social change and normalize having the conversation? We created a three-pronged strategy. The first was a very robust media campaign. And of course, we were very fortunate to have Ellen Goodman. I'm sure she doesn't have a Rolodex anymore, but she can pick up the phone and call anybody. And we have been very fortunate to have her opinions and articles in the media across the country and the world. The second was to have tools that were accessible to the public to help encourage having the conversation about what matters most to us at the end of our lives. Early, often around the kitchen table before there's a crisis. And so we have several different starter kits, one for the conversation, one for how to talk to your clinician, one for families who have critically ill children, how you talk to them, one that we never really wanted to create. And we just launched ones for families who have a loved one newly diagnosed with Alzheimer's. These kits are all online. You don't even have to register for them. They're free of charge and in multiple languages. Those were the two strategies that were proactive. And then the phone, once we were up on the web and in the ether, the phone began to ring. And communities called us and said, this is so important. We want to make our community conversation ready. We said, well, that sounds great. What does that mean? And they said, we want everybody in our community to have the conversation. We said, okay, well, we will help you do this. We will co-produce whatever this is. We've never done this, but we will do this with you. And over the course of the last 3 years, we have gone into about 350 communities. We work with indigenous leaders. This only works, as Bill said, if you had good leadership, because there's only 4 of us at the Conversation Project. We train leaders on how to spread the importance of having the conversation. Usually we bring together about between 50 and 100 stakeholders from all spectrums of the healthcare system and from all community leaders. So we bring together doctors, lawyers, estate planners, EMS people, council on aging, anybody who is interested in spreading the word and spreading the importance of having these conversations. We train them, we provide them with slide decks, with our brochures, and then they fan out into the community and create their own blueprint for change within the community. So they bring it to the Aging Gay and Lesbian Association, or the Hispanic Association, or the prisons, or the homeless. We have the creativity that has been unleashed because boots on the ground community people have owned this and taken this on as a priority. And at the same time, institutions are seeing what people want and are beginning to bring the Conversation Project inside the institutions, using our starter kit almost prophylactically. So giving it out to people who, as they turn 55, and suggesting that they go home, have the conversation with their loved ones, come back at their next visit, and have the conversation. So it's seeping both into the community and into the healthcare system. And all the things that you've heard before, the training, the systemic infrastructure in hospitals and healthcare systems, all need to take place simultaneously and collaboratively to create this infrastructure so that the conversation and the values and the preferences that are talked about here, starting with the Conversation Project or 5 Wishes or whatever tool that you like, has to be able to go through the whole system so that when you're here at that end, your values are really the underpinning of the plan of care that's created. So that's a wide and broad overview of the Conversation Project. I just would, how many more minutes do I have? Can you, okay, so I just want to give you one project that we have worked on that's a rather special project that we undertook with some funding from a family foundation. And Bill said how slogans matter. So we created something called Talking Matters. We had big posters on our subway system, the T here and the buses. And we also bought those horrible, horrible pop-up ads that you might all be familiar with that follow you when you go through on the web. They're very effective. And we ran this campaign for 6 weeks, and we had over a 200% increase in driving people to the website and downloading the starter kit. So I encourage all of us to think about a national media campaign. It was a wonderful, wonderful campaign. There were 3 families. One was an African-American couple, one was a young Hispanic couple, and one was a mother and a daughter. And it resonated far and wide. We really wanted to make sure we were hitting a diverse population. And to the Reverend's point, the Conversation Project has done its own national study. And what we learned is that if your income is less than $50,000 a year, you are half as likely to have an advanced care plan. And that people, whether it's African American or Hispanic, the driver is, in addition to ethnicity, is socioeconomic. And we have taken on a special project working with some neighborhood health centers here in Boston, the Dimmock Community Health Center. And they tested small tests of change to see how they could introduce having the conversation into their workflow. And in the end, they decided that they were going to use the Conversation Project, introduce it to everyone as soon as they're registered, because it was so universally wanted by everybody who they tested the conversation. Because rest assured, everybody wants to have this conversation. In our national study, 90% of people wanted to have the conversation, and only 30% of us are having it. So it's up to all of us to close this conversation gap. The other group that we do work with extensively is the faith community, and it is so important because that's where people do have trust and feel safe and secure. So I applaud your work so deeply. So, and I'd be happy to answer questions about that as we have a conversation together.
Well, let me ask just a quick question of each of you, and that is, this is a policy project, and both of you have referred to policy aspects of your work. Harriet, if you had a policy wish list,
yeah,
can you
great.
think of what you would
Sure.
ask the policy Santa?
So I'm sure, like many of you who work in this field, the frustration is you have the conversation, you have your healthcare agent, you have your healthcare proxy filled out, and yet when it's most needed, it's not available. It's in your lawyer's drawer, or in her computer, or it's on your refrigerator. There are a few states now that have begun a national registry for healthcare proxies so that in the heat of the moment, in a crisis, a healthcare provider can both turn to a loved one and say, do you know what's important to your loved one at the end of their lives? And in addition, they could call up the data that in like Vermont and in Oregon have it there. So I would love to see us work on some kind of national registry.
And I would like to say that CTAC has been involved with drafting legislation and promoting legislation in Washington to do exactly that. Tyrone, can you think of, I know that when we talk with the communities, a lot of people talk about the struggles they have as caregivers for someone with advanced illness. And you know, healthcare is moving out of the hospital and into the community, but many of us are a little worried that in the absence of systems in the community, that means it's going to be families more responsible for caring for somebody who needs maybe more support that can be provided. Any thoughts there on or anything else that you think from a policy standpoint would help in the communities you've worked with?
Yeah, thank you, Mary, for the question. Two things I'd like to mention. One is that I applaud this effort, but I also would like to see the Harvard Law Center also pull together a faith-based collaborative with civil rights leaders who are now the baby boomers to really talk about the relationship between the civil rights movement and also advanced care. What is it from a religious, spiritual perspective? So if that were possible, I think that that would be a tremendous conference that could be held. Secondly, one of the concerns that we all have is how do we deal with the issue of advanced care from the perspective of those who are baby boomers and those who are caring for their loved ones. One of the challenges that we all have is that many people who have advanced care, are in advanced care, also suffer themselves from the lack of respite, from the lack of support services. And so what we in our communities are doing is calling for individuals to also support those who are supporting others. In Alameda County, which was the Alameda County Care Network, we developed a process where we had caregiver navigators, and you can read that in your material. But on one Sunday, one of the churches pulled together over 1,000 people who were caregivers to really deal with the issue of celebrating their particular efforts in caregiving. And they gave over 250 awards to individuals who are part of that process. We are really trying to create a new paradigm in the movement. We agree with the Conversation Project and all that they're doing, but we also feel that it's important to go beyond that to begin to be advocates and to pull people together to really deal with issues that they have not dealt with before. And finally, our particular process is engagement with many different groups. I want to thank Corey for an award that we will receive to deal with various issues in at least 3 communities. And we're really excited about their involvement in this process. But we also have the Interfaith Network made up of Bishop Richard Address, who is a co-chair, and also Rick DeFilippe, who is here in the Harvard community, who is also one of the co-chairs, and over 150 other individuals coming from the Muslim community, coming from the Jewish community, coming from the Baha'i community, coming from the African-centric community, which is African traditional religion, coming from Hindus, which all gather together to really deal with this issue of advanced illness. It is a movement that's being created, and it is a movement that we see as affecting public policy in unique ways.
Wonderful. I think we have about 5 minutes, so please, if people would like to come and ask questions.
Thank you. Adrian Grappa, Patient Privacy Rights. The talk about the conversation this morning hasn't touched on the issues of dementia. And I'm asking particularly in terms of policy issues that might be relevant to this group. I understand it's a very complicated issue in general. So what can be, I'm not an expert in this, but how do we deal with dementia? I, as a caregiver, am healthcare proxy for my 90-year-old mom, but I'm not prepared to deal with the fact as she's become demented.
Yeah, you're right. It's a huge issue. I'm not an expert in it either, and being in a law school, I will not give any legal advice, but the starter kit that we have created is really to encourage families to have the conversation with a loved one who is newly diagnosed and is still competent to have this conversation. If that doesn't take place and the conversation happens later, the way we've framed having the conversation is envisioning what your loved one would have wanted. It's one strategy to use, but there are other people that could probably respond better.
Well, and I can say that back in Washington, the Senate has, the Finance Committee has a chronic care working group. And they sent out several ideas earlier this year where they said, you know, we're thinking about maybe some legislation around this. And one of them was to have it be mandated, not sure how you do this practically speaking, that when somebody gets a new diagnosis of dementia, that there be a prompt in the system to facilitate a conversation with their medical provider about goals and wishes. Not sure it's going to fix everything, but obviously many people recognize this issue and are trying to address it. Thank you.
Hello, my name is Ronald Stanfield, and I'm with a small company called End with Care. I'd like to address some of the comments made by Reverend Pitts, and I want to make a small comment and then question. First of all, I'm extremely glad that you are here today adding this perspective to the mix. And part of the reason why I say that is I come to this out of from a background in public policy, state government, human services, in the areas of health and mental health, and then intellectual disabilities and developmental disabilities that used to be called mental retardation. And that advocacy movement and that structural framework for responding to the newer needs of intellectual disabilities was one that was really built by, in all good faith, it was built by primarily a white, middle-class, suburban constituency, not only here but across the country, including autism and other offshoots. And it has accomplished a lot of great things. But a few years ago, I began to read literature out of University of Illinois at Chicago, began to look at issues of race and intellectual disabilities and the decision-making that was resulting from the systems in place. And not surprisingly, African-American children were often classified incorrectly, and there was this structural racial bias in this well-intended system that continues, and it affects who's declared to be developmentally disabled. Now, as we build this system, that's why I'm so glad you're here reminding us of this. As we build this system, what can we do? I welcome the addition of faith-based approach. I'm not entirely sure that going down that one street addresses some of the populations that I'd like to see included. But what can we do in this early stage to make sure that that doesn't happen, that the system we ultimately build really reflects the people most in need of care?
Yeah. I really appreciate that, your comments. I have a son that's autistic, and when he was diagnosed, we ran into some of the same challenges in terms of racism that you're discussing now. The interesting thing about him is my wife is Chinese, so he is Afro-Chinese, or whatever you want to label him, African-Chinese. And there was a real tension between what kind of programs could really support him based on his racial background. One of the things that we have been struggling with within CTAC is to make sure that American Africans, indigenous people, Asians, Hispanic, Latinos, and also people who are from other racial ethnic backgrounds are highlighted and also participate in the process as full partners, looking at their communities and also giving input from their communities into what kind of structure and what kind of organization they see would be supportive of their efforts. And so what we do is we have this candid discussion about issues of race, but also issues of class, issues of gender, and also issues of how we need to develop interconnecting relationships to deal with language. Because even as I'm naming the various racial ethnic groups, there are issues of language included in that process. The other thing that we are struggling with is within our country, in this nation, we are a nation, a multicultural nation, and we need to begin to rethink how we deal with multicultural communities. What we're doing is having that discussion and that conversation, but we're also developing networks in various communities that focus on the various racial ethnic groups. For instance, in Texas, we are looking at the Hispanic group that we're working with in Oklahoma City. We're looking at an indigenous group in Oklahoma City and in various parts of the country where American Africans are. So we are struggling with that. We don't have an answer, but we think that if we include those individuals not only in the conversation, but also in the power centers to make sure that they are part of the dialogue, but also make sure that they are part of the decision-making, will begin to move us in a different direction.
And I'm sorry, we're going to have to move to our break. Just let me build on that. Although CTAC is initially, we're only 4 or 5 years old, focused on the faith-based community, I think some of the principles we've learned from the community work could be used with non-faith-based communities. The concept of listening to the community, understanding, letting them set the agenda, helping them develop programs that meet their needs. I think those are principles that could work with any community. So sorry, but we have a 15-minute break, 10-minute break, all right.